Good day. Today I am discussing appendicitis. Appendicitis is caused by luminal obstruction of the vermiform appendix, typically by a fecalith. Other less frequent causes include obstruction by lymphatic tissue, gallstone, tumor, or parasites. Continued secretion from the luminal mucosa results in increased intraluminal pressure and appendiceal vascular insufficiency, leading ultimately to bacterial proliferation and inflammation. Left unchecked, perforation may occur. Visceral innervation produces the vague, hard to localize periumbilical or central abdominal discomfort frequently observed early in the clinical course. Progressive inflammation and subsequent irritation of the somatically innervated parietal peritoneum produces the classic migration of pain to the right lower quadrant to McBurney's point, located one-third of the distance from the anterior superior iliac spine to the umbilicus. Up to 50% of patients may have an atypical presentation due in part to anatomic variation. For example, a retrocecal appendix produces right flank or pelvic pain, whereas malrotation of the colon results in transposition of the appendix and subsequently pain to the left upper quadrant. Abdominal organ displacement from a gravid uterus may lead to right upper quadrant tenderness in pregnancy. Even so, a right lower quadrant location of pain remains the most common location of pain in pregnant women with appendicitis. The signs and symptoms of acute appendicitis lie along a spectrum that correlates with pathophysiology. Early on, patients classically complain of nonspecific symptoms of general malaise, indigestion, or bowel irregularity. Anorexia is common but not universally present. Alterations in bowel function are highly variable and can include constipation, diarrhea, and even obstruction as a late complication. Periumbilical or central abdominal pain generally develop after nonspecific symptoms. If nausea develops, it typically follows the onset of pain. Vomiting may or may not be present. Subjective or objective fever is frequent. As the clinical course progresses, discomfort migrates to the right lower quadrant. Flank pain, dysuria, or hematuria can occur given the typical proximity of the appendix to the urinary tract. Aggravating and alleviating features can help establish the diagnosis. Worsening pain with deep inspiration may be present if there is peritoneal irritation, and individuals may state that the trip to the hospital was painful, particularly when encountering bumps in the road. Such features suggest a peritoneal process is underway. The release of intraluminal obstruction with perforation often results in sudden remittance of pain, and we consider appendiceal perforation if the patient's pain has suddenly improved. As the natural course progresses, examination findings likewise evolve. Progressive inflammation and peritoneal irritation yield reproducible tenderness to palpation in the right lower quadrant. The exception to right lower quadrant pain is a retrocecal appendix, which does not contact the anterior parietal peritoneum. Rebound tenderness and involuntary guarding suggest peritonitis. Patients may have costovertebral tenderness, and percussion of the right heel or shaking of the hospital stretcher may elicit abdominal pain. There is no evidence that the digital rectal exam aids significantly in the diagnosis of acute appendicitis. Rovsing's sign reproduces pain over McBurney's point as the clinician palpates the descending colon in the left lower quadrant. A positive psoas sign or obturator test suggests an inflammatory peritoneal process. The psoas sign is elicited if abdominal pain is produced with extension of the right leg at the hip while the patient lies on the left side. The obturator test elicits pain with internal and external rotation of the flexed right thigh at the hip. The presence of abdominal rigidity, a positive psoas sign, fever, or rebound tenderness increases the likelihood of acute appendicitis. Prior episodes of similar pain, the absence of right lower quadrant pain, and the absence of classic pain migration make appendicitis less likely. The presence or absence of any exam finding in isolation is neither sufficiently sensitive nor specific to rule out or rule in the diagnosis. In both children and adults, no historical or physical examination finding is sufficient to rule in or rule out appendicitis. Despite the advent of cross-sectional radiographic imaging and high-definition ultrasonography and the more than doubling of their use in recent years, detection rates for appendicitis have essentially remained the same. There are numerous appendicitis mimics, and the differential diagnosis is broad. It tends to include other gastrointestinal diseases such as cecal or Meckel's diverticulitis, cecal volvulus, colitis or terminal ileitis, constipation, ileus or bowel obstruction, Crohn's or ulcerative colitis flare, epiploic appendicitis, functional abdominal pain, incarcerated inguinal hernia, intra-abdominal abscesses, intussusception, malrotation, and mesenteric lymphadenitis. And for genitourinary causes, these include ectopic or heterotopic pregnancy, ovarian torsion, ovarian vein thrombosis, pyelonephritis, referred testicular pain, renal colic, tubo-ovarian abscess or salpingitis, and musculoskeletal causes include abdominal wall or rectus sheath hematoma and a psoas abscess. So we have to perform a complete physical examination, including a pelvic examination in women of childbearing age. Acute appendicitis is largely a clinical diagnosis, and no one adjunctive test is universally indicated. We consider appendicitis in any patient with atraumatic right-sided abdominal, periumbilical, or flank pain who has not previously undergone appendectomy. Available diagnostic adjuncts include peripheral, WBC, and other acute inflammatory markers such as CRP and ESR, urinalysis, and the pregnancy test in women. Diagnostic imaging should be considered in atypical presentations or if significant diagnostic uncertainty exists after thorough history and examination. We can also use scoring systems such as the Alvarado and Samuel scores to aid in the diagnosis. The modified Alvarado score for acute appendicitis ranks symptoms. Migration is 1 point, anorexia or urinary acetone is 1 point, nausea or vomiting is 1 point, signs such as right lower quadrant tenderness is 2 points, rebound pain is 1 point, fever is another point, and WBC count of greater than 10,000 per cubic millimeter is 2 points. So, low risk appendicitis is a score of 1 to 4, possible or probable appendicitis as 5 to 9. However, the low risk score was demonstrated as only 72% sensitive compared to 93% for clinical judgment when appendicitis was either the most likely or second most likely diagnosis. So, another acronym for the Alvarado score is MANTRELS, which corresponds to the same things that I mentioned earlier, just phrased differently. An increase in peripheral WBC may be the earliest marker of inflammation. While numerous studies have evaluated the use of WBC, there are no clear consensus on its utility. WBC does not distinguish between simple and perforated appendicitis. CRP and ESR used alone lack the sensitivity and specificity since they are just general inflammatory markers to rule in or rule out the diagnosis. If the only diagnostic consideration is acute appendicitis, the greatest utility of laboratory tests may be in combination. An elevated WBC and or C-reactive protein may have a combined sensitivity as high as 98%. Normal values of both in patients with a low pretest probability of acute appendicitis make pathologically confirmed appendicitis very unlikely. However, WBC and CRP levels are elevated in a number of other appendicitis mimics, so these markers are not useful if the differential diagnosis of pain is broad. We also obtain a urinalysis because isolated microscopic hematuria may support a diagnosis of renal colic, and pyuria may suggest pyelonephritis. However, hematuria or sterile pyuria can be present in acute appendicitis. We document the negative pregnancy test in females of reproductive age to rule out ectopic or heterotopic pregnancy. Other laboratory tests are not routinely indicated but may be beneficial when considering other diagnoses. We also obtain early surgical consultation before imaging in straightforward cases of suspected appendicitis in adults. Imaging is not universally necessary but may be of benefit in certain populations. In children, some centers prefer pediatric surgery consultation prior to imaging with ionizing radiation. When adjunctive imaging is indicated, Early surgical consultation may aid guidance in imaging selection. The goal of imaging is to establish the diagnosis of appendicitis, avoid a negative appendectomy, identify perforation, and exclude other causes of abdominal pain with minimal radiation cost and time. Plain radiography is not helpful. Findings are typically nonspecific but may demonstrate a nonspecific bowel gas pattern or adynamic ileus. An appendicolith may be visualized in up to 50% of children with appendicitis. For ultrasound, graded compression ultrasound should be the initial imaging modality of choice in both pregnant females and children. It can likewise be considered in young non-obese adults. Reports of the effectiveness of ultrasound diagnosis of appendicitis in pregnancy are conflicting, with some reporting it as useful and others as ineffective. The appendix is oval in the axial plane, ends blindly in the longitudinal plane, and should be compressible with a maximum diameter not exceeding 6 millimeters. The normal appendix is typically differentiated from the small bowel on ultrasound by the absence of peristalsis and a lack of change in configuration over time, and its small size distinguishes it from large bowel. Typical findings in appendicitis are a thickened, non-compressible appendix greater than 6 millimeters in diameter. Doppler ultrasound may illustrate hyperemia. It is important to image the entire length of the appendix because inflammation may be more pronounced at or localized to the distal end. Given the highly operator-dependent nature of ultrasound, centers treating larger volumes of children may have greater reproducibility of high-quality studies. The diagnostic accuracy of abdominal ultrasound in children is better at ruling in acute appendicitis than excluding it. Beside operator skill, other limitations to accuracy include cases of retrocecal appendicitis or perforation, excessive abdominal guarding or bowel gas, a gravid uterus or obese habitus, a decompressed bladder, and lack of patient cooperation. Perforation may lead to disappearance of specific imaging hallmarks and difficult visualization of the appendix on ultrasound. Pelvic ultrasound may be useful in cases of suspected appendicitis and a non-diagnostic abdominal ultrasound or CT, or in the differentiation of appendicitis from pelvic inflammatory disease. In most adult males and non-pregnant females for whom the diagnosis of appendicitis is not sufficiently clear, we can consider abdominal CT scan that includes the abdomen and pelvis. Typical CT findings include a dilated appendix greater than 6 millimeters with a thickened ball, periappendiceal inflammation, and potential visualization for an appendicolith or abscess. So you could also see periappendiceal fat stranding, as they call it on CT. Luminal obstruction and dilation may be relieved in cases of perforation, leading to disappearance of specific imaging hallmarks and difficult visualization of the appendix on CT. Appendiceal CT, which is a less frequently used protocol, uses rectally administered contrast only with the acquisition of thin cuts through the right iliac fossa. This avoids the difficulties of oral contrast administration in patients with active emesis and prevents potential adverse reactions of IV contrast. Time to acquisition of images is much shorter, typically around 15 minutes after administration of rectal contrast, but may produce significant patient discomfort. Oral contrast medium has historically been recommended for CT of the abdomen and pelvis when investigating a broad differential of GI or pelvic diagnosis, and many centers continue to recommend CT imaging with both IV and oral contrast. But there is a growing body of literature that calls this practice into question. Multiple studies indicate that non-enhanced CT has excellent performance in the diagnosis of acute appendicitis. And there's also the possibility that due to IV contrast administration, some people may have acute contrast nephropathy or other renal injuries. Non-contrast CT should therefore be considered an acceptable imaging modality in the workup of acute appendicitis. In patients with renal insufficiency or dye allergy, administration of IV contrast is contraindicated. Body habitus may limit reproduction of non-contrast CT test characteristics. Intraperitoneal fat serves as an intrinsic contrast medium in unenhanced CT, and its paucity in very thin patients can affect imaging interpretation. We can also consider MRI as another reliable imaging technology in the evaluation of acute appendicitis, particularly in pregnant women. It avoids ionizing radiation and visualizes the entire abdomen in multiple planes. IV gadolinium crosses the placenta, however, and is not used in pregnancy given the teratogenic effects seen in animal studies. It is also not given to patients with renal insufficiency because it may cause nephrogenic fibrosing dermopathy. We also avoid MRI in unstable patients given the time necessary for study acquisition. Sedation may be required for small children, rendering it impractical in many pediatric cases. Patients with acute appendicitis typically require appendectomy, so immediate surgical consultation is needed. They should be maintained on NPO to avoid operative delay, and we resuscitate the patient with maintenance IV fluids with appropriate antiemetics and analgesia. Initiate perioperative antibiotics upon diagnosis or if the patient exhibits signs of peritonitis. Appropriate choices should broadly cover aerobic and anaerobic gram-negative organisms. Acceptable regimens include ampicillin sulbactam 3 grams intravenously or a pediatric dose of 75 milligrams per kilogram IV, piperacillin tazobactam 4.5 grams IV, or 100 milligrams per kilogram IV, cefoxitin 2 grams IV or 40 milligrams per kilogram, or metronidazole 500 milligrams IV plus ciprofloxacin 400 milligrams IV. Given the non-operative management of uncomplicated diverticulitis, salpingitis, and neonatal enterocolitis with antibiotics, some suggest a similar non-operative approach to uncomplicated acute appendicitis, but this is not yet the accepted standard of care. And special populations include pregnant women and children. Pregnant women warrant special attention because it is the most common surgical emergency in pregnancy, appendicitis that is, and delay in diagnosis is the greatest cause of increased morbidity in the pregnant woman with an acute abdomen. Ovarian torsion and ectopic or heterotopic pregnancy are additional considerations. If abdominal ultrasound is non-diagnostic, we consider pelvic ultrasound, CT, or MRI. Many radiologists avoid CT in the first trimester given teratogenic concerns of ionizing radiation. In addition, although iodinated contrast material is safe in pregnancy, we avoid IV gadolinium. Children are also a diagnostic challenge, particularly if they cannot adequately verbalize their complaints. In such cases, physical exam, parallel history from the parent or guardian, and a high index of suspicion are keys to accurate diagnosis. Pediatric imaging should begin with ultrasound, but many centers advise early surgical consultation before any imaging if appendicitis is a consideration. Our reference is Tintinalli's Emergency Medicine. Thank you.